So one thing I focused on a little bit is to start to think about, how do we keep things simple? How do we make sure that we ask simple questions that give us simple answers and not overcomplicated? I think a second thing that's related to this, and I think I do have to credit Mark Rattain as one of my mentors here also, is that we still develop drugs the same way we did 35 years ago, even though the drugs we're developing are so much different. And one principle is that when we started, a lot of the agents we had very narrow therapeutic windows. In other words, the dose that was effective was very close to the dose that was highly toxic. And so therefore, we developed designs that focused on giving what, in essence, was the highest tolerable dose. But that's not the case with things like the hormone therapies, the immunotherapies, and so forth. And so we are now dosing drugs in a manner that doesn't make pharmacologic sense, and we need to go back and revisit that. And I would say that the third thing that's sort of struck me, and in some ways prostate cancer is the poster child for this, is that the underserved are not participating in our trials. And the example is that 10 to 15% of the prostate cancer population in this country is Black. If you look at all of the major studies in prostate cancer, you're lucky if 2% of that population is Black. And we know that the Black population, at least in certain degrees, has different incidence of certain genetic abnormalities. And so we actually don't even know that our therapies are representative and appropriate for some populations. So melding some of these things together, simplifying the trials, and making sure that we can get some of our underserved populations to be part of our clinical trials is one of my initiatives these days.